Hi, I'm Dr. Robin Roth, but my friends call me the Boobie Docs, my popular social media account where I talk about breast cancer and breast health in an educational and fun way. I'm a board-certified radiologist who specializes in breast imaging and image-guided procedures. I'm also a 40-something Ashkenazi Jewish woman with a strong family history of breast cancer and BRCA, so I know a thing or two about breast cancer. And this is my podcast, The Girlfriend's Guide to Breast Cancer, Breast Health, and Beyond. If you or someone you love has been affected by breast cancer, this podcast is for you.
The Women's Health Initiative, I don't know why we're still talking about the Women's Health Initiative. The Women's Health Initiative, the average age of the woman in the Women's Health Initiative was 62 years old. That's totally postmenopausal. That's 10 years older than the average age of menopause.
I am so excited to be joined by my friend, Dr. Suzanne Gilberg-Lenz. She is a board-certified OBGYN, and she's also board-certified in integrative medicine, which I'm excited to hear about. She's the author of Menopause Bootcamp and a breast cancer thriver herself. But many people, including myself, know her as Dr. Suzanne from the Drew Barrymore show. So welcome to the Boobie Docs podcast. I'm so happy to have you.
Thank you for having me. It's so nice to be on your pod, Dr. Robin.
Thank you so much. We have so much to talk about, but first I wanted to start about I wanted to hear about your own breast cancer journey.
Okay. I don't really know where to start. Take me back.
It's like, how were you diagnosed?
So it was an interesting situation for me, right? Because I'm an OBGYN. I've been in practice for 24 years. So at the time, I was diagnosed in October of 2013. So this is almost 10 and a half years ago. And I was, doing my routine. I know all the screening guidelines, although things seem to be changing. Although, are they really? We'll talk about that, I guess.
We're definitely going to talk about that.
Right. No, yeah. I was actually in this mode of... I consider myself to be fairly low risk. And I had started my screening mammograms as we do at 40. And at 46, I had a normal mammogram. I had very dense breasts.
Okay.
We did all the things that you do. And then and I had a mode of like, look, I'm not going to do it every year.
Yeah.
Just okay. Let me just say this about me. I am board certified. I practice evidence-based medicine, but I'm one of these people who doesn't like to take Tylenol. So I one with patients. They don't freak me out, and I understand where they're coming from. Right. So I had my babies in a hospital. You know what I'm saying? Right. But I also if I don't have to have an intervention, my preference is not to have an intervention. So this is also not a highly anxious. Very straightforward. I mean, I'm a surgeon. Really, do you think you're going to scare me? Not really.
Right.
So I think that's important. I am. I think that's an important context to put. I'm not one of these people who's in every 5 seconds, thinking that I'm dying. Although in medical school, I thought I had MS, just, FYI.
Right.
So I feel like the context is important. So about 9 months later, after a normal mammogram, I was in the shower and I felt something that was undeniably cancer. I have diagnosed cancer. And at that point I had diagnosed lots of cancer. And I was like, wow, that's definitely not normal. And then I was like, well, let's see, it's getting smaller and bigger with my cycle. And also my daughter's bat mitzvah was coming up. And I was like, I'm not dealing with this right now. So I probably felt it in August. My daughter's bat mitzvah was in October. As the bat mitzvah was done, I was like, okay, I got to deal with this. Had my imaging, and the radiologist, I always did go to a private radiology office where I saw the radiologist personally, and he would do mammogram, ultrasound, and I would have my results before I left. So even though I just said I'm not highly anxious, this did stress me out because my breasts were dense, and I just wanted to know, and it was worth it to me, and I was able to have access. I was able to afford it, and he felt it and saw it and was like, you need to biopsy this.
Right.
And I was like, yeah, no. So I had core biopsies, and this was a Thursday. I was having lunch with friends on Friday, and he called me and he was like, it's cancer. So I had infiltrating ductal carcinoma. I don't remember the grade. I think it was low grade, grade 1, estrogen and progesterone receptor positive. I the most common kind of early breast cancer. And I'm very, very fortunate because I knew all the people who I do, and they're my friends and my colleagues. And I called my friend who's a breast surgeon, Christy Funk, who's actually quite famous at this point.
She's wonderful,
and, yeah. And my other mentor, Dr. Philomena McAndrew, who people in the breast cancer community, an OG breast cancer oncologist, really great. And, they just rallied the troops, and I had all the things. So the order of business is you get a breast MRI, you do genetic testing, and then you get your final results, map out where else there may be cancer and what your risk is. And I was young. I was, well under premenopause age. I was 47. And it was really shocking to me, Robin, because I did not consider myself high risk. Now, when it came to under family history afterwards, that I wasn't as low risk as I thought. I'm not a BRCA, but I had genetic testing just before a newer, more expanded panel with some of these, what we call variants of unknown significance, and for variants that we now know are higher risk. So things like CHEK2, ATM, PALB. I'm bringing these up specifically because I want your listeners to hear these words. There's no pop quiz.
Right.
But I think understand that we're in an interesting situation. Like, I know you've probably talked about this, but we know that only about 10% of breast cancers that are diagnosed are genetic in basis that we know of. Then there are other genetic variants that we know are increased, have management strategies around other than increased surveillance. And then there's these, what we call variants of unknown significance. We see them where they exist. We don't really know how much do they increase your risk. So I was tested before all these were included on the panel, and I'm mentioning that and I'll get to it. So I waited for my results because I knew that if I was a BRCA carrier, I was going to be having bilateral mastectomies because my risk of recurrence was so much higher, and I was young. And I also knew I'd be facing other surgeries, preventive surgeries. So I was, as an OBGYN, I was not excited about that. And I wasn't a BRCA carrier, and my MRI showed disease elsewhere, but enough that I could do a lumpectomy and radiation. I was offered a mastectomy. My decision was not to do that. I didn't want massive surgeries. And I was willing to live with the treatment plan, which was that I would have to have radiation and I would have to be on chemoprophylaxis, so medication, for a certain number of years. And that was my decision. I didn't want to have huge surgery. And I knew that my was actually the same, that my mortality was the same. And I was willing to bargain. Actually, even if there was a little bit increased risk of recurrence, I knew my mortality risk wasn't any different. And that's what I did. So I had surgery and I had radiation and I took tamoxifen. I did not take it the whole time because I had really bad side effects. And I also understood the numbers. Mm-hmm. So it's true. And this is where I think patients and the general population have the shit scared out of them. And I don't appreciate it at all. I think it's bull. My risk of recurrence with the FIN, which is an estrogen receptor blocker, is 100% higher. However, my absolute risk goes from 4% recurrence to 2% recurrence. Highly significant statistically, not clinically. This is where
you're willing to
part ways.
Yeah.
Yes, I'm an adult, as is every other woman who is diagnosed with breast cancer. And this is where I part ways with some of my colleagues, where they freak out and they freak everybody out.
Yeah.
You don't understand those actually a very low risk for me.
Right.
Maybe for you, it's not. Maybe there's no 0% risk, by the way, folks. That's not a thing. I already had breast cancer. So that's cat's out of the bag. Okay. So this was my decision-making process. And I was really empowered because I'm a physician. I knew that. And I had a team that were colleagues and friends who were very adept at navigating these waters with me. So important. But I also know how lucky I was. So that's my story. So I did tamoxifen for a while, had horrible joint pain. And I was like, no, this isn't a thing. First of all, I'm a person. Second of all, I'm a surgeon. I'm not doing this. So I stopped. And I did get to a complete 5 years. It took me probably 7 or 8 years to do that. And when it got to the 5 years, the data had changed, and I was recommended I do 10 years. And I was like, because my risk is not high enough for me, so you can F all the way off. I love doing. I'm not doing that. She was like, what about a Visto? And I was like, no. And she was like, okay,
we're done here.
I get it. I hear you. And I'm 10 years out.
That's incredible.
And now I will tell you, I'm 10 years out and I'm on a menopausal hormone therapy.
Yeah, there's so much I want to talk to you about, because I think, you brought up so many points about like going through a disease process as a healthcare professional is kind of a mind
wild
F, Yeah, right. Because you know too much. Like, right, you felt the lump, you knew it was breast cancer, you knew that you have dense breast tissue, and the likelihood, unfortunately, is, so how was that? I mean, I guess it affects every decision you make. You could overthink everything.
I'm not an overthinker. It's really weird. And I think, it's trauma response probably.
Yeah.
But it works out well.
That's good.
I'm a person, like an obstetrician. So like I'm used to being the eye in the storm and like being extreme cool and collected. And I'm good at my job because of that. Now, emotionally, maybe that's not so good, right?
Yeah.
But I got very clear about like, these are the facts. These are my goals. This is my team. I also don't not listen to my team,
right,
but I have my own opinion, and I knew what I knew and what I didn't know. Mm-hmm. And I understood, but I was coming in as a very informed participant. And like I said, look, my way of being is like calm, mm-hmm. because I know from my professional life, if I'm freaking out and my executive functioning is shut down, I am not going to take care of patients. I'm going to kill somebody by accident. Seriously, I've never done that. So I'm not planning on doing that with myself or anybody else. I don't mean to be facetious. That's just like a person at work.
Yeah.
And I know from my own experience as being on the other side of the table, making the diagnoses, patients hear like 5% of what you say the first time.
100%.
I just had this conversation with a patient yesterday that I'm super close with. I'm close with her family. She just had a biopsy result, and like really having to talk her down after having talked to the breast surgeon. And I, reached out to the breast surgeon and said, like, I know you guys didn't do anything wrong. She's just like, she's freaking out.
Yeah.
Which is a normal response. So the only thing that really freaked me out was the genetic testing, because I was just like, I have two little, they were kids. They were like maybe 12 and 15. So, I was just like, our chemo. I remember when I sat down and told the kids, my daughter freaked out, ran out of the ring like, Mom is going to have chemo and lose all her hair. And I was like, Mommy's not going to have chemo. Actually, that's not part of the treatment plan. So I know this is really scary, but I'm not even going to look scary. I'm going to be my same annoying self.
Right. Yeah. Telling your children about a breast cancer diagnosis is incredibly tough, especially when you're bringing in genetic counseling, like you said, to the mix. What are some of your tips for like talking to your family about your diagnosis? And also, like, you've talked a lot about genetic testing and the different panels and things like that.
Let me say one thing. So here's the thing. The new genetic testing came out about 18 months later, and I made a decision not to do it. And the reason was that I knew there would be no change in my management based on that test. So as a physician, you should not be doing tests that you won't be responding to. I mean, if you want to go on a fishing expedition and you're curious, that's okay. That's a reason. But the way I was trained really old school at a big county hospital by really old physicians who actually had quite a bit of wisdom. And they always said to me, like, look, if you're doing a test and you don't have a plan of action based on those results, why are you doing the test?
100%.
So that was the way I felt about it. I think at some point, I know that if management strategies around genetic predispositions change, then I will, because I want my children to have that opportunity to make decisions that make sense for them, because the chances of them carrying something that I carry is 50%. But at the time, I'm suspicious that actually my family too, because of our other family history. We have a lot of prostate cancer, and it turns out we did have more breast cancer than I thought. Mm-hmm. But we don't do things differently. In other words, we don't do preventive surgeries and things like that for checking. We just do more surveillance, which I'm already doing. And my kids are in their 20s. They wouldn't be getting surveillance now anyways. I mean, I really thought this through. So I know a lot of people are like, how did you not do the genetic testing afterwards? that's how. So having said that, I think people need to understand these concepts, and it's always a decision making.
Mm-hmm.
I think that I totally lost the forest for the trees here, but I think you're asking me like, what would be my advice around this, about talking about this with your family?
Yeah.
It's so emotionally hard and so stressful and puts you into literal fight or flight, because you are like, you have cancer, which, doesn't matter how the rational mind works, that's like you're going to die. And in your 40s, that's really not what you're thinking. You think you're like, planning for retirement, or what's the kids' vacation, that's where I was like, oh, Hanukkah's coming up. Okay, no.
Yeah, no one's planning on getting cancer, right? It's a life quake. And
like, why would you do that?
Right.
Why would you do that?
I know.
And I was like, I'm super healthy. And by the way, doing yoga, meditation, organic, integrative health, really
doing all the right things.
Shape. I was like literally in the best shape of my life.
Right.
So, then those things, it turns out, are not a protective shield. Like, shit happens, and it's not a punishment. So there was a lot of stuff I had to unpack emotionally. And I think my advice to people, gather your resources, have your, my partner, my now ex-husband, my husband at the time was super present and like so supportive. And so like there for the kids and for me. So have that person. And if you don't have a partner, friend, mentor, family member, coworker, somebody, you need to have a person who you can do the dumping on, kind of vomit the stuff, so you can collect yourself, so that you can speak to the people who are vulnerable and who need you to continue to be the adult in a way that makes sense. I think it's not about not being vulnerable, but I think for children in particular, they need to hear the truth and also feel safe, continue to feel safe.
100%.
As a mother, that's what anyways. And that was really hard. And it was hard for me to have to then get to a point where I had to be vulnerable. When I was doing radiation, I was working full time. And my ex was a producer on location, which was a conversation we had. And I said, no, I need you to go make money. Go. Goodbye.
Right.
I was very lucky. I had family in town. I had girlfriends in town. I had people who helped me. I would come home and I had the last appointment of the day for radiation therapy, and then go straight home and get in bed. That was hard to be vulnerable like that. I was used to being boss lady at home.
100%.
It was hard for them.
As a type A personality, like all of us physicians definitely are, I know how this is not something that no one's planning for, a cancer diagnosis, and it completely throws off your plans. And it's such a life quake. My friend described it as, it shakes you to your core and just makes you reevaluate everything up to this point.
Yeah. Oh, I mean, my whole life changed after that. And a lot of it got real clear about what was ripped to me. The other thing I will say is that, again, I'm very, very fortunate to have like wonderful friends that are like family and a community around me. But one of the first things that happened was my two closest friends came to me and said, okay, we're now in charge. So your job is to take care of you, and we will create a wall around you. I mean, if you want us to. And I was like, yes. Because I'm weirdly I'm public, but I'm actually extremely private, and especially for a lot of reasons. And they were like, so we're going to create a meal train, in charge of it. I mean, one of my closest friends since I'm 4 years old just was amazing and just said okay, so people can't talk to you unless they talk to me first. And I was like, that's fine.
That's incredible.
They created a phone tree, and they created a lot of rules to bring interesting. I think it was a New York Times essay around that time that showed it was these sort of concentric circles, and that information has to be controlled on the way out and on the way in. So the center is you and whoever you're close. For me, that was my kids and my husband, my immediate family, my close friends, and then my wider circle. And also that includes how other people feel about what's going on with you is none of your business, and nobody needs to share that with you ever. It is not your job to hold space for anybody.
100%. And I love the idea of protecting your peace and having people around you to help, because you need to focus on being positive, on getting through the taxing schedule of treatment that you're going through, while trying to, keep your house together and your job and make it look like you have everything together when in fact everything is crumbling around you.
Yeah, or not having it together, or not.
We're not.
Like, if they didn't were 100% correct that they didn't want me to feel like I needed to take care of anybody else around their feelings. And I do remember, like, look, because I was out and about and I was working and stuff like that. And once people started hearing in the community, that, who are you? It was like literally my most dreaded.
I don't want to deal with it.
Even though people really mean well and they want to acknowledge it. But I was like, I don't feel like talking about this. Like, I'm trying to do your cervical exam.
Right.
Or whatever it is. Like, because I had to go back to labor and delivery and the operating room and all this stuff. And it was intense. Or like, I'm going to tell you, for a really long time, reading other people's normal mammogram reports was incredibly triggering. It made me so angry. I was pissed. I was like, that is not fair.
I can imagine that. I mean,
as a doctor, it was like, I was like ashamed. I mean, 10 years later, I can be like, I was like, yeah, totally. Yeah. I was like, why is this 65-year-old have a normal fucking mammogram and I have to go through this?
Right. It would be really hard not
to. That didn't feel good.
Right. But you let that pass out.
I'm sorry.
Sorry for the people.
Oh, yeah. I'm like, whatever. It's like, check.
Right. So you mentioned that you were average.
I know, there's a lot to talk about.
I know, I want to get to it all. So you mentioned that you were average risk for breast cancer. You didn't have any identifiable risk factors. You were healthy. You were doing all the things, maybe skipped a mammogram here and there. But, I guess, what's the take home on that? Most people who are diagnosed with breast cancer don't have the family history, don't have the risk factors that we typically see for breast cancer. So what's your take home message to everyone listening?
My take home message is get your mammogram. And also all the things that they say, like these U.S. Preventative Services Task Force trash.
It's like, let's talk about that.
Yeah, no.
No.
Here's the thing. These are large organizations that are pooling massive demographic data, and it's a lot of the cost benefit analysis. So it's like, this many breast cancers costs us this much, so it's acceptable. Here's the thing. In this country, this to a mammogram every year after the age of 40. And even if you don't have insurance, there is a low cost. I mean, I shouldn't say it. If you live in rural, underserved areas, it's really hard. So that's actually not true. But in a larger city, even if you don't have insurance or money, there are low or not available. You have to access them. You have to advocate for yourself. But you should be getting your imaging and you should be doing your breast exams. I found this mass myself, okay?
I'm so happy you mentioned that, because the American Cancer Society no longer recommends a self-breast exam as of 2015. And
that's so weird.
It makes no sense. It's like, look, but don't touch, and we know that there's a rise in breast cancer.
It's also like, I feel like actually so misogynist, and it's don't empower yourself, don't touch your body. It's not worth it. What are you even talking about? In an era where we have so much gaslighting, which is documented, but then the actual official position is don't know your body. I really think I think are not paying attention to this anyways. And I think doctors need to get their acts together and actually stop being so butthurt and defensive when you hear what your patients have to say. Stop, take a beat, don't personalize it, and take it in. Are curious and listen. Patients are being gaslit. I have been that patient, not in this setting, not with this specific. I have definitely been gaslit on many occasions as a female physician, as a female human, as a patient. I'm telling you, it happens all the time. And sophisticated, and I have a big mouth. So women are being gaslit. The idea that you shouldn't touch your body and know your own body. I tell my patients every time I do this, and I've been doing it a long time, I'm never going to know your body as well as you are. Even if I'm the only gynecologist you see in life, you're going to know your body better than I will. So let me teach you what I know, and you need to go with your gut instinct. If I never listened to a patient who had a gut instinct that didn't make sense on paper, I'd have a lot of dead bodies in my trail. You need to listen. You got to use our most powerful tools are tools of deduction, which require us to listen. And every patient who says something that doesn't make sense to you is not crazy.
Right.
It's just basic human decency.
100%.
So I think I want to spend ridiculous.
we have to listen to our patients, right? We know that about 80% of young women are finding their own breast cancer. So we have to take their concerns seriously. And I also think that medical societies need to get on a consensus here and provide the most life-saving information and let women decide if they want to come every year or two for a screening mammogram. And if they want to learn how to do appropriate self-breast exam so that they have the tools to find their own breast cancers, because we know that young breast cancer is on the rise and we're not educating. We're telling people not to do it. All of this is so confusing and conflicting.
It makes no sense.
It makes no sense. I can't imagine the insurance companies not being behind, these recommendations that are behind the U.S. Preventive Task Force. And I mean, I hate to say it, these societies that are not supporting just common sense breast health.
It's low-hanging fruit. I mean, and then I think the other side of it is that people get very, very scared about imaging too much, about exposure to radiation. I think there's a really lack of education around how much exposure you're getting. I say to my patients, so you don't get on an airplane?
100%.
And then they're like, oh, I'm like, yeah.
I have to deal with this all
forever.
I have to deal with this all the time. There's so much medical. I know you do too. Like, for some reason, mammograms and HRT, I feel like are the ones that get the most hate online from just, people that spew nonsense. And the dose of a mammogram is incredibly safe. It's equivalent to flying cross country. Mammogram is not perfect. We need to also, especially in women with dense breast tissue, we need to be supplementing with ultrasound or MRI, depending on their risk factors. Yeah. And I really think that, there's a camp of people like myself that believe that we need to start breast cancer screening sooner. You need to identify.
Really interesting.
Well,
yeah.
It's really
we're seeing because you're seeing more young breast cancer. Yeah,
young breast cancer, and it's definitely having a conversation about your breast cancer risk factors earlier, so before the age of 30, because these recommendations are for average risk individuals, and that's assuming that everyone understands their risk for breast cancer, and most people don't. And like you said, the two greatest risk factors for developing breast cancer are being female and getting older. So by definition, we are all at risk here. So, taking that into consideration, I think that we just need to offer clear guidelines as to what young women who should be concerned about breast cancer need to know and get serious about breast health.
Yeah. And then understanding viable risk factors. Like, I think everybody gets up in arms about certain things and then they don't want to talk about alcohol, which is a class 1 carcinogen. So,
right.
I went out to dinner last night and I had a glass of wine. Okay. I'm not saying, but I'm just saying, know what you're doing. People are freaking out about, but are they not drinking alcohol? Especially younger women.
Yeah, I think you have to pick your vices, right? Because I also love alcohol sometimes, and I'm willing to accept that as a risk factor, but I know that it's a risk factor. But there are lots of environmental factors that are out of our control. And then there are also lots of lifestyle modifications that, like lowering alcohol and not smoking or vaping and not having a sedentary lifestyle. All these things go into play. But I do feel like that there's something environmentally going on.
Oh, I think so too. It's really alarming. And I had this conversation yesterday at my office. Some of it is look, I'm aging with my practice, and so picking up breast cancer recently. But I do feel like it's in younger women. I know that's totally it's anecdotal, but
it's actually
that's
not.
Definitely a reflection of what I'm seeing in terms of the statistics, and it's distressing.
It is 100%.
It's distressing to me.
Most of the people that I diagnose in my practice are under the age of 45, and I will tell you, I'm seeing patients in a inner city community, and also in a they have all access to all the best, imaging. And it's still, we're seeing younger breast cancer, advanced breast cancer. And, it's very alarming. I think that the latest data...
We could go on and on about that.
The latest data actually showed that it was increasing in younger people about 2% per year. And it's actually declining in the older population. So it is moving towards a more younger and middle-aged population. Very scary.
That is scary. Yeah.
So I wanted to, you talked about tamoxifen, you had lots of side effects, and then you which is a common, medication used in cancer. How did hormone replacement therapy help? And let's talk about that.
Well, first of all, let me just say that this was a long slow to get there, because for sure, I didn't think I'd be in hormone therapy, because especially 11 years ago, I knew that the Women's Health Initiative, I'm not talking about the Women's Health Initiative. I mean, I knew a year into it, it was clear to most people who were practicing OBGYNs that this data was not applicable widely. We'll just leave that alone. I don't want to eat up time on that. And there's the whole conversation online that if you follow the menopause, you got.
I was going to say, a lot of stuff came out yesterday. Yeah.
Yeah. I mean, well, it keeps coming out, right? So I'm not talking about that. I just was like, even though I knew that hormone replacement therapy doesn't cause breast cancer, because that's actually false information. I was premenopausal, and it seemed to me at that time there wasn't any data to be supportive of using hormone replacement therapy when it was. So I was like, well, okay, I guess that question is answered. And I mean, luckily for me, I went into menopause quite late, which I think is interesting, and it makes me wonder about other parts of my profile, right? Because, anyways, so I sort of was like, okay, I'm not going to do it. For sure, I was going to use vaginal estrogen, and I already was. Because I knew that that's not absorbed systemically. And then I started reading more of Dr. Avram Blooming and Carol Tavris's work, Estrogen Matters. He's an oncologist who focuses on breast cancer. He's actually not in practice anymore. He's here in Los Angeles. And for 30 years, he had been studying menopause hormone therapy and breast cancer. And honestly, I think a lot of people viewed him as an outlier. Now he has really been, he's being published in all the big journals, Menopause and the like, and people are understanding that his work is really groundbreaking and very important. And he's not the only person, but people have hit, and Jim Simon is another leader in the field of menopause. These are very, very important academic physicians, demonstrated repeatedly by aggregating data and also looking at their own data that it's really not the relationship that people think it is. So just because the tumor has receptors for these hormones doesn't mean that these hormones are causing cancer. And also, I'd like to point out, I don't think people realize that, other non-reproductive tumors have hormone receptors. Brain cancers have hormone receptors. So people need to understand, we don't always understand the complex and nuanced relationship between breast cancers and even general health. So that's sort of the foundational information there. But we also know that the majority of, to this point, we'll see what ends up happening, the majority of women who are diagnosed with breast cancer are diagnosed like I was. I mean, I was younger than the average age. And I wasn't that young, but I was younger than the average age. I was premenopausal. The majority of us are diagnosed with early stage breast cancers, probably 70 to 80% of us. And the majority of us are going to die of heart disease, not breast cancer. Even if you have a breast cancer recurrence, die from that. You're going to die from heart disease or dementia or osteoporosis. Those are much bigger killers, much bigger killers. And hormone therapy really has been demonstrated repeatedly to reduce those risks. So really, are we doing a disservice, not just in the day-to-day, which is a substantial cost, but are we creating more and worse and more prevalent medical problems by withholding hormone therapy? Right. And the more I looked at this data, I was like, wait a second. My recurrence risk, without treatment is really low, especially 10 years out. My mortality risk from this is extremely low. I mean, extremely low, right? It's like
99%.
99%.
Yeah.
5-year survival rate, Okay, well, I'm now, I've passed that. So, and I don't want to have dementia, and I don't want to have osteoporosis. And then one of the things that started happening to me, and I'm a weightlifter, I had osteoporosis.
Oh, wow.
What the fuck?
Right.
So I was like, this is bullshit.
Right.
And then, I was vitamin D and heavy eating well. And then as I got closer to really entering the actual, post that year that I was in postmenopausal, you don't know until you're there. My sleep was really disrupted. My hot flashes started getting really worse again. And I was just like, this is done. I can't function like this. Estrogen Matters. I had years to marinate all the information. I was like, this is bullshit. I'm going to start hormones because I think it's actually going to save my life. And if nothing else, my day-to-day right now is important to me. And so I started hormone therapy, and that I couldn't be happier. It's not, I just feel so much better. Like I don't even know how I could have continued to do it, because the sleep disruption alone was so bad. And I know the data. Again, dementia risk increases with lack of sleep. Now, let's not forget that I also spent 25 years of my life or more really not sleeping at night, which is really bad for you. I looked at all the information, and I didn't talk about it publicly for a while, because I knew that if I say it, patients are going to, like, I didn't want to influence people. I don't know. I think I just felt, and I knew that I was a little bit of an outlier. Now people are talking about it a lot more. And I think, honestly, being involved in the menopause movement in the way that I have been, and really working closely and collaborating with a lot of colleagues from across the world and across the country, really helped me understand how important sharing my story was. And Dr. Corinne Menn, who you also probably know, who's an incredible menopause advocate and a breast cancer survivor, who she can tell her own story, but she's a genetic carrier. She was diagnosed very young, in her 20s, has a really interesting and amazing but difficult story. And she's been very, very public about that, and super, super, super evidence-based, one of the smartest people I know. And she really encouraged me to be open about it and share, because it's powerful information. And that's what I decided to do. And I started talking about it publicly, probably in the last couple of months. Because I knew that, again, my story of how I made decisions, what evidence I used to help guide me, and what resources I had to support me were important for other people to hear about. And I'm not trying to influence. Nobody don't have to do this. They need to know that it is an option. I say this all the time. It's not informed consent if you don't have all the information.
I love that. And so I love how you call it the menopause movement, because I have noticed, like, I've never really paid much attention to menopause until all these incredible women doctors have been talking about, the benefits of HRT and why it might weigh the risk of a slight risk of recurrence or, breast cancer. Because we know that the side effects of having low estrogen are very detrimental, like you said.
Yeah, and I think that the data on hormone replacement therapy having an influence on breast cancer, and I'm not talking people like myself who've had breast cancer, but in the population, the data is not really there to show that. That is, it is inaccurate to say that hormone replacement therapy or menopause, whatever we're calling it today, causes breast cancer or is even associated. It's actually inaccurate. That's not what the data says. And we have a lot of work to do, because women are very, very scared about breast cancer. And again, I would like them to take a page from my book, understanding that you're not all me, but take a beat, assess the information. If you have a care provider, a practitioner, a doctor, a nurse who's scaring you, that's really not how we educate. That's not how we educate people. So I think I have a lot of thoughts on the obsession with breast cancer. I think it's misogyny. I mean, I had breast cancer on anybody, but there's something about sexuality, the way we present, femininity, and misogyny. If you don't have boobs, you're not going to be a woman anymore. So you 100%. Should really be scared of this. Forget your heart disease. We can't see that, and that's unsexy. But if you have boobs or don't, that represents something culturally. I'm not saying people are doing this on purpose, but I think there's this really primal response. And that's why it gets so much more play than osteoporosis, which is somehow very unsexy. Fracture in your later years has a huge, you have a huge increase in risk of mortality in the year when you hip fracture. I mean, what? People need to know that.
Right. And that will kill you before your breast cancer, and hopefully in many cases.
100%.
Right. 100%. I think that's a really important take-home point there. What did the most recent data show about that? I know that a lot of people are quoting this JAMA article that came out the other day. So what does that data show? How did the Women's Health Initiative get it wrong? If you in 2 minutes or less.
I can't really quote it. Basically, how it got it wrong in terms of breast cancer The data was massaged. First of all, the Women's Health Initiative, I don't know why we're still talking about the Women's Health Initiative. The Women's Health Initiative, the average age of the woman in the Women's Health Initiative was 62 years old. That's totally postmenopausal. That's 10 years older than the average age of menopause. So right there, we're not even looking at the same population. So that's a huge problem. We know that all the risks, I just said all these things, heart disease, dementia, cancer is much higher in a 62-year-old than in a 52-year-old, period. A lot of these women already had cardiac problems, for instance. Wow. So the data is, and then we're looking at things like Premarin and Provera, which if you're using that anymore, you got to stop. This is not even like modern medicine. So there's just a million things, like it's just not applicable. And then the way they massage the data, like I just said, the 100% increased risk from 4% to 2% with me. Well, they did a lot of that stuff with the data. And when in fact, even in this older patient that without HRT is at increased risk of breast cancer, we just talked about that, and all these other things on Prem-Pro. The women who, the increased risk was actually, the raw data is 0.8 per 10,000 users. Mm-hmm. For every 10,000 women that were on that protocol in this demographic, less than one of them got breast cancer. Oh. That is clinically not significant. And then you look at the data of the women who didn't have a uterus and were on estrogen only, Premarin, oral, they had a lower risk of breast cancer. So just like even this terrible data actually doesn't tell you what you think it tells you. So it over and over and over. I mean, I don't know. I don't think JAMA's doing a great job. I think JAMA is also recycling a lot of the stuff that is done. Yeah. The Washington Post is doing a good job, I think.
I saw that. I know. That's getting a lot of press. It's good. I feel
as it should be, because it's peeling back the layers of the onion to explain in lay people's terms what this information means. And it's interesting to me. I think there's a lot of politics in here. I think the people who devoted their lives to the work that they did, and God bless them, we appreciate their
service, right?
Their service, but they're really, really married to something that I think was a mistake. And it's 20 years let it go. And I do think it's also a response to the grassroots power that is being demonstrated right now. And the cat's out of the bag. Women are online. Women are talking to each other. Women are listening to people like me who are not academic.
100%.
Mary Claire Haver, who is not academic. Just because we're not academic doesn't mean we're not smart. And we take care of patients.
We know we know what's going on out there. We are the pulse of the people. Sometimes I feel that way. And I also agree with you about the media doing a better outlet than a lot of the organizations, because it's like the USPTF came back and said 40. Of course, no shit. We've all been doing that. Like all the experts have been saying 40 the whole time. But like, why are we like doing these crazy every 2-year things? Because of anxiety, right? Like I agree. It's very political. It's very misogynistic. There's something going on. And the women we're getting word of it. We are angry, as we should be.
Women are tired of it. Women are tired of not being heard. I think the other thing here that I do want to say, because obviously we all came out of academic institutions, we appreciate the work that organizations do on our behalf and on the behalf of the American public. I don't want to just paint them with a broad brushstroke, but they tend to be very conservative. And I tell people it's like turning a cruise ship. They are, and I don't think Robin and I are like anti-evidence, but at a certain point you have to use your clinical judgment as well and base it in some scientific reality. And sometimes they lose the forest for the trees kind of. And, in terms of the research world, and that's a lot around funding and things as well. But for the organizations, they have it set up so that they've got to have like a preponderance of a certain kind of evidence that is not always realistic to perform. And then they refuse to sort of shift. I think some organizations are doing this better than others, but they're very, very, very conservative and slow moving by nature. And the thing is that people need information now. Like you just said, we're seeing a big shift in who's getting cancer. We can't wait 20 more years for that data.
I will tell you, I'm actually at an academic institution, and I do think that people might be changing their minds a little bit on age, on hormones, as they probably should be. So, but I love hearing all the sides, and I think all of it. I agree that sometimes these big organizations are slow to make changes that need to be made. Absolutely. before I let you go, I wanted to play a game of Would You Rather, okay?
Oh, okay.
Okay. Would you rather get a colonoscopy or a mammogram?
A mammogram. Mammogram is faster.
Okay, good. Okay, a mammogram or a pap smear?
A pap smear is easier because I can do it in my own office.
Okay.
Does that count?
You can't do it yourself, right?
No, but my nurse practitioner can. She's doing it Monday.
Okay. Pap smear or, this one's unfair, pap smear or an esophagram?
Ew, what? A pap smear? Are you crazy?
I just wanted to make sure.
Blah.
Right. And before, I couldn't think of another screening test that was unpleasant that could go in that game.
I'm not doing that one.
And I have to ask, how did you get to be the doctor on Dr. Drew, which is honestly my dream job?
When my book came out in October of 22, they invited me on to promote the book. And, Drew is very, very interested in midlife health, and she's very focused on her own experience and wanting to share that with others. And we just really vibed. She liked the book. I think, honestly, what happened is that show was very popular. It was, it was really interesting. Like, the book just came out at the right time and everybody was like,
Right.
So, and I've done a lot of TV. And I knew people there and they're like, come back. And she kept having me back. So
that's awesome.
Turned into that. So
I have to tell you,
it's really, really fun.
It looks like the most fun thing. I've now tried twice to go see Drew Barrymore. This is a really funny story. For my Boobie Bash, I have this annual party called the Boobie Bash. You should totally come, but you're on the West Coast. But so one of the auctions items, my friend got me 4 tickets to see the Drew Barrymore show. So I auctioned with me. And so, and then these ladies bid on it, and I never met them until we went to go see the Drew Barrymore show. And they're all breast cancer survivors that love the Boobie Docs. So we pile in my minivan and we drive down to New York, and we hit terrible Lincoln Tunnel traffic, and we missed the show. We got there 20 minutes before showtime, and they wouldn't let us in. But we had an amazing day in New York. And then we tried to do it again. Oh, I know. But we saw.
Well, maybe third times we should talk about this.
The third time is the charm, and I'm going to come back. We got to come see the Drew Barrymore show. Maybe a day when you're on.
Absolutely.
Oh,
I would love that. That would be so much fun. I would love, love, love that.
Yay. Well, thank you so much for coming on my podcast. And I really love your energy, and I love everything you stand for. And thank you so much.
Oh, Robin, thank you so much. And thank you for what you're doing for people and giving people a voice and really checking the reality out there.
Thank you. I appreciate you too. Have a great day. And you
too.
All right. Take care.
Take it easy.
Okay, bye.
Okay.
Thank you so much for listening to this episode. If you enjoyed this conversation or learned something new, please go to Apple Podcasts and leave me a 5-star review and help spread the word. If you tell me you did, I'll give you a big virtual smoocheroo. And of course, make sure you follow me across all social media platforms at the Boobie Docs for more of the breast information. And a huge thank you to my podcast producer, Christian Cuveta, an amazing medical student who also wrote and produced the music for the show. Take it away, Christian.